In this lecture, we will look at the skills, techniques, and interventions used in conceptualizing our clients and using that information to begin formulating treatment plans. When we formulate treatment plans, we want them to be individualized to our clients. They should take into account all of the unique factors and information related to the client and the signs and symptoms they present with, so that we're matching their needs as best as possible. So let's begin by looking at some terminology. What does case conceptualization mean? It's actually more a process than an event. It's the process we use to begin to piece together and understand what it is that is going on with our clients. In other words, how do we make sense of their needs? When clients present to us for counseling or services the first time, our goal is to take all of the information that they bring with them, all of the information that we're able to gather either through verbal communication or nonverbal communication, and put it together like pieces of a puzzle to best understand what their overall problem might be. This conceptualization then forms the framework for all the work we'll do with that client. Our understanding of what their problems are helps decide what it is we do to treat these individuals in terms of services offered, treatment approaches used, and theoretical orientations selected. Since case conceptualization is best viewed as a process, we could look at the different stages one goes through in formulating a conceptualization. In the first stage, we look at evaluating client concerns. Before we could begin treating an individual, we need to know what it is that they want to be treated for. We can evaluate clients using observations, assessments, and measurements. There are many ways that we can gather information from clients. Through observation, we're able to see the presentation of the client. Are there any outward visible signs of their distress? Perhaps they look disheveled or distraught. They appear tearful or anxious. These observations provide us with key clues that could be used in the conceptualization process. We also could look at assessment. Through assessment, we gather information related to symptoms, interviews with the client, with key members of the client's family or close personal circle, provide us with insight into how the client is functioning outside of the counseling setting. In other words, we get to see how they act at home, how they feel about what's going on in their lives. And then finally, through measurement. Measurement allows us to get quantifiable data about a client and their problem. Measurement may involve administering a test or instrument. In some cases, you may even begin using a battery of tests to further understand a client's problem. Once we've gathered all the information, we could proceed to stage 2. Here, we begin organizing all of these observations. Organizing them in a way that allows us to identify patterns or themes. Perhaps there are reoccurring issues that come up in a client's life. And then stage 3, we select a theoretical orientation. Based on what we now know about that client, what is the theoretical approach that we would take and view as the best possible approach for that client and that situation? So let's look at each of these stages in a little more depth. So stage 1 is our evaluation. We're gathering information to better understand the client. Some things that we take into account during this first stage, questions that may be important for us to answer for ourselves. What is the primary reason for the client to be seeking help at this time? Knowing why a client presents for counseling can be an important piece of information in planning out the treatment that you implement for that client. Why this time? For the overwhelming majority of your clients, their problems did not begin overnight. The issues and problems they're dealing with most likely have been there for quite some time. So what is it about the present moment that finally made them come seek counseling? Why didn't they not come a week ago? A month ago? In your evaluation period, you should be trying to find out why the person came at this time. This lets you understand where they currently are in their management of the problem. A second key question to look at is who brought the client to counseling? Did this individual come voluntarily on their own? Or were they made to attend counseling by an outside source, whether it be a family member, a school administrator, employer, or officer of the court or legal system? Clients who present voluntarily for services obviously are more invested in participating in the process. Those who attend against their free will are less likely to be participatory in the process and may require a different set of skills and techniques for the counselor to employ. Third, we want to try to assess the client's understanding of what their current problem or issue may be. It seems common sense that individuals who present for counseling clearly could tell you what's wrong with them. If you present to the doctor, you're typically able to clearly present the symptoms that you're experiencing. With mental health issues, though, it may not be as black and white. Clients may not be able to verbalize the exact symptoms they're experiencing. Rather, they may just be able to tell you that something doesn't feel right. They don't feel like their normal selves. Or, in some cases, they may be able to tell you the symptoms they have, but really not understand how they began or how they've escalated over time. Sometimes it's a client's lack of understanding of their current problems that's beneficial to the counselor. When clients do not have preconceived notions or ideas about what may be wrong with them, they're typically more open to explore and look at different perspectives as to what might be causing their current level of discomfort. Also occurring in this first stage is the beginnings of our diagnostic formulations. It's here where we begin diagnosing clients. So what is a diagnosis? Well, the word diagnosis means distinguishing or discerning. So when we diagnose clients, we label their problem or disorder. A diagnosis then is simply a label. What is this client's problem in a neat little package? Now keep in mind that diagnosis is different than conceptualization. It's a component of conceptualization. Through conceptualization, we're able to understand all that's going on in the client's subjective world. Piecing all that information together allows us to come up with a label that describes their experience. For example, major depression disorder, bipolar disorder, schizophrenia, ADHD. All of these are diagnoses that could be given to a client. When making diagnoses, it's important to keep in mind the concepts of parsimony and hierarchy. Parsimony speaks to the ability of the counselor to be succinct. When making a diagnosis, it's best to choose one that fully encapsulates as much as possible of what's going on with a client. In other words, look big picture rather than at individual pieces of the puzzle. Medical doctors do not diagnose you on each of the individual symptoms you have. They diagnose you with the overall disorder. The same happens in mental health. Because a lot of these disorders that we will talk about have similar signs and symptoms, and in some cases overlapping diagnostic criteria, it's best to pick the more overarching diagnosis. With that in mind, there's a hierarchy that we should look at. This hierarchy shows us, in a crude form, which disorders are more prevalent in terms of their reach and spread in a client's life. Which disorders would be most pressing or most important for us to deal with? This hierarchy is based on the syndromes or clusters of symptoms that clients present with. There are some symptom sets that are more severe than others. This severity necessitates our treating those before addressing other less vital or less imminently dangerous symptoms. So let's look at the clinical hierarchy. There are actually 9 different categories. Each of these categories relate to syndromes or clusters of symptoms. The first is the most severe. This is what we need to address first with our clients. And it proceeds downward from there. In theory, you should be able to look at this list of syndromes and target where is your best starting point with your client. What is the highest level for that client? Now this is again just used as a guide, and you should evaluate each individual client based on their individual needs, concerns, and presenting problems. The first category is medical issues. It's important to first look and identify if there are any medical concerns or potential medical or biological causes for the client's current symptoms. Medical issues take precedent over psychological systems. There may be something that needs to happen medically before we could even begin to address the psychological. Many of the disorders in the DSM actually contain this stipulation, where counselors and clinicians are asked to assess whether or not medical conditions may be at play in a client's life and thus causing the current presenting symptoms. Next, we look at psychotic symptoms. Is the client actively hallucinating or delusional? Clients who are in a psychotic state typically pose a greater danger to themselves and others than when they're not under the influence of thoughts or voices or images they are fabricating. We then move on to mood issues. Depressed mood. Does the client have symptoms that would be consistent with any of the depressive mood disorders? Anxiety issues. Somatic concerns. The somatic disorders relate to physiological or bodily disorders and ailments that have a psychological component to it. We then look at sexual disorders or sexual dysfunctions. Those are then followed by personality disorders. There are several personality disorders identified in the DSM. Adjustment disorders. Clients who are having difficulty adjusting to new situations or circumstances in their lives. And then finally, V codes. Recall the V codes are those diagnostic formulations that are really sub-threshold. They're problems or concerns in a client's life that do not rise to the level of a diagnosable disorder. V codes could represent relationship problems, stress at work, school-related stress, and things of that nature. Although we rank these in a hierarchy, it's really not to indicate that certain issues are less important than others. For example, clients who come in with adjustment or V code related issues should not receive less attention or less effort than others. The hierarchy is simply designed to help you be more parsimonious in your approach to working with clients. In other words, a client's mood disorder may be predicated on somatic symptoms, sexual or intimacy related issues, adjustment issues, and other V codes. So addressing clients at the mood level subsumes all of these other levels. By treating the one, we're able to treat all the others as well. This is the definition of a parsimonious approach. Stage 2 is where we begin taking information, gathering all of this information, and starting to put it together. The information we gather comes from many different sources. We can get information from the client. For a variety of reasons, however, self-report is not always the best possible source of information. Clients may be unaware of certain issues in their lives. They may be attempting to conceal information, either to avoid repercussions or for secondary gains. As a result, we often look at secondary reports, talking to others who could provide us a more objective view of what's truly going on for that client. As a school administrator, when teachers send students to the office, that principal or administrator rarely relies on the student's self-report to ascertain the reason why they were sent to the office. Instead, that administrator typically will ask the teacher what was going on and perhaps seek other outside evidence to support the claims made. Observations also come into play. As counselors, we can observe for ourselves what's going on in these clients' lives. And then finally, we could use tests and assessment, getting more valid and reliable information. When we assess individuals using tests and other assessment devices, we want these instruments to be both reliable and valid. In terms of reliability, we want them to be able to produce consistent measurements. Are we able to get consistent results time and time again from an instrument? If results are inconsistent, it's typically indicative of a poorly designed instrument. As a result, it doesn't give us much useful information. When we talk about validity, we talk about accuracy. Does the instrument accurately measure what it purports or sets out to measure? A depression screening instrument should in fact help me identify whether an individual has depressive symptoms occurring in their life at this time. When looking at validity, there are two terms that we talk about: sensitivity and specificity. Sensitivity is also referred to as positive predictive power. And to repeat, sensitivity is referred to as positive predictive power. What that means is that a test or instrument that is high in sensitivity presents a likelihood that one will test positive if they have a specified mental disorder. In other words, a client who does have depressive symptoms in their life should take a depressive screener, and that instrument should show that yes, they do in fact have depression. The opposite is specificity. Specificity refers to a negative predictive power. This negative predictive power means the likelihood that one will test negative if they do not have a mental disorder. So if you go to the doctor, you don't have a disorder, you don't have the symptoms of a disorder, but they're unsure, they test you for it to rule it out, and the tests come back negative that you don't have the disorder. That is specificity, the negative predictive power. So with all of this information that we have pieced together, we could then begin look at making a structured treatment plan, something that is specific and works for that individual. As we do this and begin making a diagnosis, there are some steps to take into consideration. When making a diagnosis, there are 7 steps to follow. First, we need to collect the data. Collect all the information we can from as many different sources. And then identify psychopathology. What seems to be going on here? What clusters of symptoms or syndromes do we see going on in this individual? Is the information we have reliable? Was it obtained from sources that are credible? Using the hierarchy we talked about, what's the most prominent symptom cluster? We can then begin making our decisions on arriving at a diagnosis. What is the problem that we're labeling for this client? To ensure the accuracy of our decisions, we check the diagnostic criteria. Did we fully address each of the possible criteria for this disorder? Does the client meet the required number of elements to be given this diagnosis? If not, we resolve any uncertainties. Any issues or areas where we may have a need to go back, gather additional information, or resolve any conflicts or discrepancies that may come up. The information we gather from clients also needs to be screened. Some factors to consider. What's the history of the present illness? As I mentioned earlier, how long has this been a problem for the client? It's likely not something that began overnight, but has it been going on for a few days, a few weeks, a few months, or a few years. Knowing how long the current problem has existed goes a long way in determining the treatments we identify. We also want to look if there's any previous mental history. Has this individual been in counseling or received any type of clinical care in the past? This information provides us with several insights into the client. For one, we gain a better idea of the history and scope of the problem. Is it recurring? Has it been a problem for the client in the past? Also, it gives us a head start in the treatment planning process. For now, we could identify what the client has done previously to attempt to address this issue. What has worked? What has not worked? We could look at personal and social history. Relationships, interpersonal relationships, romantic relationships, marital status of the individual. All gives us insight into their ability to interact and communicate with others. We could also look at their academic or employment records to see if there are any issues there. And then finally, we look at family issues. Are there any family history? Are others in the family experiencing similar issues? There's a strong genetic component to many disorders that we talk about. Knowing whether or not these disorders or mental illnesses run in a person's family is important to determine. Although we may be thorough in gathering information and piecing together this puzzle, there are several challenges that come up. These challenges sometimes make it difficult to arrive at a diagnosis for our client. One of these such challenges relates to the idea of causation. When clients come in for counseling, one of our goals, and hopefully one of the client's goals, is to identify the cause or the root of their problems. Clients want to know, why am I acting this way? Why do I feel this way? Unfortunately, there may not always be a cause of the problem. There may not be one singular moment or issue or event that we could look at and pinpoint, this is why you currently feel this way. In fact, many problems may have multiple factors that contribute to their existence. There may even be factors that initiate the problem, perpetuate the problem, and exacerbate or heighten the problem. For example, imagine working with a teenager or a young adult. and that individual has become hooked or addicted to a particular type of drug. In working with the client, we try to identify what's the cause. What led to this addiction? Well, there may not be a singular cause. They may not be able to say it was Tuesday, March 12th, 1991, when it all began. There may be multiple causes. A lack of self-confidence or self-esteem, peer pressure, stress, family environment. Failing to identify a cause may be challenging. It's hard to denote what the problem is when you don't really know when the problem became a problem. We also look at predispositions. A predisposition is a latent susceptibility one has to a disease or disorder that becomes activated under certain conditions. So we may have a susceptibility hardwired into who we are. And certain conditions activate that. For those of you old enough to remember the Incredible Hulk television show, Dr. Bruce Banner had a predisposition. When he became angry and agitated, he morphed into the Hulk. He had this hardwired into him, and certain conditions or stressors brought it out. The same is true with alcoholism. We talk about there being a strong genetic component to alcoholism. You may have a history of alcoholism in your family, and thus be predisposed to the disorder yourself. But it takes the condition of you consuming alcohol, putting it into your body, for the problem to begin. And then finally we look at volition. This deals with the willingness or free will of the client. Is the client experiencing signs and symptoms that are within their will? In other words, could they stop? Could they change if they wanted to? Sometimes there are things that clients, despite their intentions to change, they just can't change. Other times, change may be well within their reach, but they choose not to for a variety of reasons. So as we diagnose clients, it's important to look at what can change and what cannot change. And then finally, that third stage is choosing a theoretical orientation. Picking a theory that will allow you to best address and understand a client's issues. The theory you choose provides you with the perspective you take. Multiple theories can be used to view the same problem. And counselors coming from different theoretical viewpoints or orientations would see the problem, its impact on the client, and its potential root causes in different manners. Choosing a theoretical orientation and allowing that to be your guide or the lens through which you view your client will help you better understand the symptoms they're describing, the personality traits they're exhibiting, the thoughts or cognitions they report having, their feelings or emotions, and their behaviors or actions. Throughout the history of mental health services, there have been several different paradigms we have used. These paradigms are conceptual frameworks. So a paradigm is a conceptual framework that provides us with general agreement about what's going on. The different theories that you've been exposed to in your counseling program all fit into these clinical paradigms that have been developed. Paradigms become the general consensus operating mode of understanding that we use. Over time, paradigms change, and we experience paradigm shifts. As new information and new technologies become available, we change our understanding of the world. Where at one point everyone was convinced that the world was flat, and if you traveled a certain distance, you would eventually fall off the face of the earth, changes in technology and our understanding of the world evolved. We no longer saw the world as flat, rather it was round. You now could sail around the world. This paradigm shift changes our perspective. This changed perspective opened up the world to new exploration. Had we never changed our viewpoint, we would still have isolated groups and peoples in this world who had no idea that others existed. When we think of paradigms, there are some characteristics indicative of a paradigm in general. For one, they present us with a pattern of thinking. This pattern induces bias. We look at clients and begin interpreting clients' thoughts, feelings, and behaviors a certain way based on the paradigm we're following. They also provide us with a framework for conceptualizing our observations. What we see and what we observe, what does it mean? For example, following a behavioral paradigm, we may have an understanding of conditioning and how conditioning molds and shapes behavior. So when we see clients acting a certain way, we're able to conceptualize those observations. We're able to begin thinking, what is it that's supporting that behavior? What's the reward or the positive reinforcement the client is gaining for that behavior? Paradigms also provide us with assumptions that govern these observations. What do we believe goes hand in hand? For different disorders, we have some assumptions that clients who have this disorder will behave this way. Now, that's not absolute, but it's a general rule of thumb that seems to work. These general rules of thumbs or sets of rules allow for continuity or reliability in our observations. They provide us with a way to link together what it is that we observe in our clients. In terms of counseling and mental health treatment, there have really been 6 major paradigms. These different schools of thought at one time or another were the dominant method of understanding human behavior and mental illness. It was through this perspective that all treatment was designed and implemented with clients. Again, with additional information, advanced technologies, we're able to change and adapt and grow in our understanding. This growth leads to the development of new paradigms. All of these are still available and readily usable by you as a counselor. Unlike the previous example, with the world being flat, here previous paradigms do not necessarily become obsolete and outdated. They still can be used. It then becomes important for you as the counselor to choose which is the best approach for your individual client. And so we'll briefly look at each of these paradigms. First is the biological paradigm. The biological paradigm is based on the premise that mental disorders are caused by alterations in biological processes. In other words, deviations from normal biological functioning result in mental illnesses. One type of biological approach we could look at is genetics. When we talk about behavioral genetics, we're talking about looking at individual differences in genetic makeup and how they contribute to differences in behavior. What is it that's hardwired or coded into our DNA that makes us act and behave the way we do? For those of you with siblings, there has probably been a time in either your life or that of your brothers and sisters where you've wondered, how are we possibly related to one another? We act completely different. So what is it about your genetic makeup that determines or predisposes you to act and behave a certain way? When we talk about genetics, there are several key terms we need to keep in mind. The first is genes. Genes are the carriers of genetic information, your DNA. The specific grouping of genes that you inherit from your parents is known as a genotype. An equal number or portion of information is inherited from each parent. 50% of who you are comes from your mother, 50% comes from your father. This inherited material, your genotype, forms the foundation of who you are. Now, not everything you inherit becomes apparent. There are situations where some of your genetic material becomes dominant and other becomes recessive. Those dominant genes are what we see as we look at an individual. Those observable profiles are referred to as phenotypes. Examples of phenotypes are eye color or hair color. We also could look at heredity as being a diathesis. This means that it can change. Over time, as a function of an interaction between you and your environment, these outward expressions or phenotypes could change. Here, an example may be intelligence. You may have inherited genetic qualities that make you an intelligent person. This intelligence is then shaped by schooling. Where you went to school, how long you went to school, opportunities you had made available to you. There are several different types of genetic studies that can be done to look at how genetics may shape or help us understand mental disorders that individuals experience. In the family method, we look at creating a family history or family tree and identifying who has mental illnesses in that family. You typically start with what's called an index case or proband, and that would be the client. And then work out generation by generation to see who has what disorders. Parents and children, as well as siblings, share 50% of their genes. So if in an immediate family, the nuclear family, there is a mental illness present, there's a 50% chance that this index or proband client may develop it as well. These percentages drop off the further you move from the nuclear family. For example, cousins or second-degree relatives only share a 25% chance of having a similar diagnosis. A second approach is the twin method, looking at disorders as they occur within twins. The type of twin that you are determines the likelihood of you sharing genetic coding for a particular mental disorder. Identical twins, or monozygotic twins, share 100% of their genes. If one has it, the other will as well. For fraternal or dizygotic twins, there's a 50% share. Although they were born at the same time, they share the same amount of genetic material as siblings born at different times would, 50%. And then finally we look at the adopted method. Several years ago, studies were done that looked at children who were separated and adopted by different families. Reared in different environments, researchers were able to determine whether or not a disorder was the result of genetic coding or conditioning. Would the individual have developed this disorder regardless of where they were raised and the environment in which they grew up? Or did that environment play a key role in the development of that disorder? Within the biological paradigm, we also look at chemical imbalances. Neuropsychology is becoming an increasingly more important factor in mental health. Our understanding of the brain and how it functions is growing rapidly. When we talk about chemical imbalances, we're talking about nerve signaling and how the brain relays messages from one part of the brain to the other and throughout our body. This information or communication is transmitted through what's called neurotransmitters. Neurotransmitters are the vehicle through which information travels along the neural pathways. 3 primary neurotransmitters that have been found to be significantly related to mental disorders and mental illness are dopamine, norepinephrine, and serotonin. Mental disorders are typically related to these neurotransmitters and specific problems. 1, there may be too many or too few of these neurotransmitters available to you. You may be producing too many, and thus the message gets lost, or too few, and there's not enough for the message to carry from one nerve cell to another in your brain. There may be a problem with too many or too few receptors. The message may be sent, but there's no one there to receive it on the other end. Depending on the type of neurotransmitter and the problem associated with it, different types of psychotropic medications may be prescribed. In a coming week, we'll talk about psychiatric medications and how they affect brain functioning. But different types of psychotropic medications are used to address each of these neurotransmitters. MAOIs, monoamine oxidase inhibitors, tricyclics, and SSRIs, selective serotonin reuptake inhibitor. Each address a different type of neurotransmitter. So depending on what is diagnosed as being the issue, that particular medication may be prescribed. Shifting away from a medical or biological perspective, we could look at the more cognitive-based paradigms. As always, we begin with the psychoanalytic paradigm. Freud and psychoanalysis are the epicenter, or kind of the beginning view of mental health from which all other approaches have emerged. In the psychoanalytic paradigm, the key is the tip of the iceberg theory. In other words, your conscious thoughts represent only a small fraction of what's really going on in your brain. In fact, up to 90% of your brain activity occurs at a largely subconscious or unconscious level. You're simply not aware of what's going on. Now, in his theory, Freud had many different components to this psychoanalytic paradigm. He talked about the id, the ego, the superego. There was discussion of developmental stages that an individual goes through. The oral, anal, phallic, latent, and genital stages. In essence, what Freud talked about was how childhood experiences and how we dealt with childhood developmental issues help shape our adult personality. He also talked about anxiety in the presence of objective and neurotic anxiety, with objective anxiety being anxiety we felt that had a clear and definable precursor. You're afraid of snakes, and there's a snake sitting on your desk. Objective anxiety. Neurotic anxiety was anxiety that you had that was anticipatory. You're afraid of snakes, so you avoid places that you think snakes may be, or there's a likelihood that a snake may appear. Psychoanalytic theory also gave us defense mechanisms. These defense mechanisms were our attempt to control anxiety, to alleviate feelings of anxiety in our life. The problem with the psychoanalytic approach is that many of the concepts cannot be observed or measured. The approach is really a ex post facto explanatory approach. We're able to explain behavior after it's happened. We can tell clients, this is why you're acting this way. But it doesn't allow us to predict and prevent behavior from happening. In the behavioral paradigm, we looked at different types of conditioning, classical and operant. Classical conditioning is the work of Pavlov in pairing together conditioned and unconditioned stimuli to produce conditioned responses. In operant conditioning, we looked at positive and negative reinforcement, as well as positive and negative punishments that could sculpt and mold behavior. With social learning, we look at the work of Albert Bandura, who talked about how we use others as a form of modeling. Watching others gave us insight into how we should act. These approaches gave us ways to change or shape behavior. Methods such as systematic desensitization and aversive conditioning were used. With systematic desensitization, we pair relaxation with previously stressful stimuli, and over time, a connection is built, and we no longer feel stressed by stimuli. The more often you come into class and there's a snake on your desk and nothing happens to you, the more accustomed you become to that, the more comfortable you become with having the snake there. In aversive conditioning, we pair unpleasant events with a stimuli to reduce attractiveness. Punishments that we give individuals. Speeding tickets for speeding. Spankings for misbehaving children. Despite the many successes, there are some shortcomings with the behavioral approach. Reinforcers that we use are not standardized. A counselor needs to individualize the reinforcement structure they have. What you offer as reinforcement to clients needs to be personalized. $1 is a great reward to a 6-year-old, but not so much for a 46-year-old. The behavioral paradigm also assumes that all disorders and all behaviors are learned. But that's hard to explain for some disorders. For example, schizophrenia. How do we explain schizophrenia as a learned behavior? Again, based on these shortcomings, other approaches emerge. The cognitive paradigm. The cognitive paradigm looks at mental processing, how individuals perceive, recognize, judge, and reason. Our concern here is with how people view the world, structure the world, and understand their experiences. These thought patterns can cause disturbances of emotions or behaviors. Individuals may have irrational beliefs or faulty cognitions that become crystallized in their mind. And as a result, they cause certain emotional responses or lead an individual to behave or act a certain way. Understanding what the root cause is and what the cognitions behind these behaviors is the key to this approach. A shortcoming of the cognitive approach, though, is that individuals need to be self-aware. They need to be able to reflectively look upon what it is that they believe and think. And that could be challenging to some clients. The humanistic paradigm, which begins with the works of Carl Rogers and moved on to people such as William Glasser, emphasized free will and choice. Individuals have the freedom to make choices in their lives based on how they want to live. So the focus is not on how the problem developed, but more on how the problem can be solved. If you truly want to change it, what are the choices you need to make to change it? Now, some assumptions of this approach. One, people can only be understood from the vantage point of their own feelings. We can't put ourselves in other people's shoes. We could try to simulate, or as best we can, understand how clients feel, but only they truly know how they feel. It also assumes that healthy people are aware of their behavior and have good purposes and intentions. That may not be the case. In working with clients, empathy becomes a big component. Being able to understand the subjective experiences of the client. We communicate empathy in two different ways. In a primary method, we communicate to the client our understanding, acceptance of what they're thinking and feeling. In advanced empathy, we infer what's going on with the client. We can empathize with how they're feeling based on what we know to be underlying what they say. They may not come out and say that they're distraught or emotionally drained, but we know individuals that go through a similar circumstance, for example, a major illness, a divorce, loss of a loved one, we can infer what someone going through that must be feeling like. And so we're able to exhibit advanced empathy. And then a current approach we look at is the diathesis stress model. And the diathesis stress model actually serves as an umbrella approach over all these other paradigms. It's based on the idea that we have a predisposition and there needs to be some environmental trigger that sets it off. So it's a combination of many of these approaches. Put together, how does this information help us? It allows us to formulate a treatment plan. In formulating a treatment plan, we need to define the problem. Well, depending on which theoretical orientation we've used, the problem will be interpreted differently. The problem may be more of a behavioral issue, a cognitive issue, or an emotional issue, depending on the theoretical perspective you assume. Once we define the problem, we need to establish goals. The goals we set with our clients need to be explicit, concrete. They need to be measurable. A goal of a client wanting to feel better is not very measurable. How do we know what that means? How do we identify and interpret the term better? Goals should be obtainable, but not too easy. We don't want to make them out of reach so that the client decides not to make an effort to reach them because they're out of reach, but we don't want to make them too easy that they really give the client no sense of accomplishment. We want to select interventions appropriate for that client, derived from the theoretical perspective we take, and appropriate for the individual. And then finally, we need to identify how outcomes will be measured and assessed. What will we look to determine whether or not we were successful in helping a client? So this is an overview of the conceptualization process. As we get into individual disorders later in the semester, we'll come back to this and look at how this process plays out for each individual disorder.